Hello and welcome back to the Patient First Podcast. I'm your host, Dr. Bryan Laskin. And as always, I'm excited that you're here. And I'm really excited we have an amazing guest today, Dr. Allison Stolz, who's a primary care physician. And as you can tell, if you're watching this on YouTube, in the studio today. Thank you very much, Allison, for being here.
Glad to be here.
Well, and we've known each other for quite a while.
Yep.
You know, our kids were our friends, and so this is. I'm really excited because you are, as I mentioned before we started recording, really our first physician on the podcast with this new format where we're actually talking to physicians and patients about, how do we put patients' overall wellness first? Dental and everybody in dentistry talks about the medical dental connection, how oral health is a gateway to overall health. And I always say, and I've said it on this podcast, people don't talk to physicians about this. I've been going to meetings and like the health meetings and the some broader medical meetings, but we don't have conversations with physicians enough. And I thought you would be the perfect physician to start off with because will give me the honest truth.
I'm very blunt.
Yes, yeah. Just beforehand, you're saying you haven't called me stupid,
but I've called your ideas
my
stupid.
idea stupid. Yes,
yeah,
yeah.
Once or twice.
Yeah, well,
you have
could
a lot of good
more.
ideas too.
Thank you.
Yeah.
Well, I have probably more bad ones, to be fair. But so I want to kick us off. Could you tell us a little bit about your practice?
I'm a family physician from Minnesota. I went to school in Minnesota. I've worked in a variety of different situations. I've worked for an FQHC, a federally qualified health center, which is a sliding scale clinic for people who are uninsured and underinsured. I've worked for a big health system. I did that for maybe 15 years. I worked briefly as a fill-in at a prison. That was exciting. And for the last about 4 years, I've been an independent contractor locums doctor. So that's a fill-in doctor.
Okay.
Yeah.
Oh, and you've worked with, different ranges too, right? Because you worked with eating disorder.
Yeah. As part of working in primary care for a while, I was working part-time in just regular primary care and then part-time in eating disorders. So doing the medical assessments and intakes.
Wow.
So mental health, physical health, and a little bit of thought about dental health.
Well, FQHCs, it's interesting because I didn't even know that you worked with an FQHC, which is actually big in dentistry. There's a big FQHC component, and a lot of the dental FQHCs are kind of on the front lines of this medical dental integration.
Oh, interesting.
So,
I didn't know that.
Yeah, well, that's my point now, because you kind of highlight, I think, where my suspicion is, and my suspicion is that in the dental world, everybody's talking about the medical dental connection, and in the medical world, people
not at all.
Not even thinking about it.
Almost not at all. I mean, we think about it when somebody comes in, and we love this, by the way. Somebody comes in who we've been telling forever, you've got hypertension, you need to go on a med. And they go, oh, doc, I'm going to do it with diet and exercise. Visit after visit, and you talk to them about the risks, and you cannot get through. And then they go to the dentist, and the dentist refuses to do some procedure on them because they're 200 over 115. And they come in and they're finally ready to address their hypertension, their high blood pressure, because the dentist told them to. And we're like, great, keep doing this thing. Their blood pressure is partly up because they're going to go to the dentist and they're afraid of the dentist. I don't care though. It's the one thing that finally gets some of these guys, it's usually a guy, to take their blood pressure seriously.
Wow.
Yeah.
So
it's sort of like good cop, bad cop. I love it.
So in dentistry, we talk about the connection between periodontal disease and diabetes.
Oh, yeah.
And, now they're finding the bacteria from periodontal disease in the brains of Alzheimer's patients and stuff.
Yeah.
But your example was the hypertensive patient that went to the dentist and the dentist wouldn't see them. Wow. That's now, and as a physician in an FQHC, you weren't even really aware of this medical dental integration as much.
Well, a little bit in that many of the FQHC medical places will have ours. The one I worked at didn't, but some of them have a dentist there.
Mm-hmm.
So in that sense, yes, there was better integration. The teeth of people who go to an FQHC are often really quite bad, from the little ones to the pregnant ones, which is, the risk factor too for the premature births, and terrible gums, terrible teeth, terrible oral health in general. So in that sense, yeah, there's better integration there because there's often an on-site dentist.
So let me put a thesis towards you, because this is how in my brain, I if I were a physician, I would be viewing dentistry.
Okay.
I view it as a checkbox that is either basically like a stoplight. It's either red, yellow, or green. Either.
We have that on Epic right now, which is, they get a big red. They haven't been to the dentist in a year.
Oh,
And I ask them during their physical, have you been to the dentist? And they go, oh, yes, last week. And then I switch it over to green. So
okay.
it is an actual checkbox with red, yellow, and
Oh,
green.
I wasn't even aware of that.
Yeah.
If it is green, let me ask.
Okay.
My suspicion is that you would never think about the patient's oral health.
Well, I hardly think about the check boxes, let's be honest, because there's like about a million checks box. There
Oh,
are,
okay.
yeah. I mean, there's so many check
Yeah, yeah.
boxes for so many different things. So oral health is sort of on the lower. There's just a lot of
No,
things.
that's
There's
why
a
I wanted to
lot of
have you on it.
things.
Yeah, yeah.
Okay. I do think about oral health. I think about it perhaps more than the average doctor. I don't know. I think about sleep apnea is a big part of what I talk about. When I see somebody who has a mouth that looks like sleep apnea,
Hmm.
I always bring it up. Um, so that's not exactly oral. Well, it
It
is. I
is.
mean,
Yeah.
it's the overlap between us.
Well, and
Um,
so let me just pause you there before you go on to your next use case, because when it comes to sleep apnea, a lot of dentists you know, they focus exclusively on sleep and doing mandibular repositioning appliances
oh,
to
they
help with
do.
that. Yep. That was, and your shock
Explain. Yeah,
answers my next
yeah. Okay.
question, right? Which is like, because as a dentist who treats mild to moderate sleep disturbances with a an oral appliance, which is effective. Well, yeah,
Ooh.
well, can be effective. I don't. Okay,
Okay.
well, controversial in your mind.
It's effective rarely, and the people who it is effective for are very happy about it, but there's a lot. It's sort of the broken promises of the oral
Oh wow,
appliance.
wow.
A lot of disappointment. A lot of I paid this amount of money and it didn't work.
Oh really?
Yeah,
Well,
yeah.
you'll probably have some sleep dentists who will make some comments based on
Fair enough.
your
Fair enough. See, I'm
perspective here.
pissing people off
Yeah,
already.
I love it.
Yeah.
So you answered my next question, which I was going to go, because from it's kind of a microcosm of the oral dental medical integrative space, where on the dental side we're like, well, we need to get a sleep physician to give a checkbox that this is mild to moderate, so that then we actually can produce an oral appliance for the patient. And on the physician's side, I was going to ask, do you ever refer patients to a dentist to get an oral appliance? And I would suspect the answer is no.
I mean, here's the thing. I'll believe that it helps mild to moderate, but not a lot of people are willing to treat mild to moderate.
Mm, sure.
I can't get people to go for an assessment when it's mild to moderate. They're still in the range where their wife pokes them and says roll over, and that fixes the problem because it's mild to moderate.
Mm.
You know, the majority of the people I send for sleep studies, it's moderate to severe, and they need CPAP. And getting them used to CPAP is very, very difficult for a lot of them, but can be done. But it needs a lot of hand holding and a lot of sort of out of the box coaching.
That makes a lot of sense. I hadn't thought about it from that perspective.
Yeah,
Yeah,
I
the
mean,
people you're
great.
seeing. Yeah, yeah,
If I had
yeah,
mild sleep apnea, I'd want a mouth appliance too, rather than CPAP.
yeah.
But a lot of these people, they have more severe than that.
Do you get involved with the other use cases? I'm thinking of like temporomandibular joint disorders or head and neck cancers. Um, does that fall kind of in your I would assume you see patients with both of those. And do you see yourself collaborating with dentists at all? Oh, do you see?
Well, let's talk about the head and neck cancers first, because
Mhm.
this is another thing like hypertension, where you guys doing it reinforces what we do. You guys do the uncomfortable look see with looking under the tongue, and you get the hands in there, and you're pissing the patient off and making them uncomfortable. That is helpful. It's a good thing, like it's the
I
good
love,
cop
I love,
bad cop thing.
yeah, I think the exact would be said from dentists to physicians, right? You're doing the
Okay.
uncomfortable thing that's outside the mouth and like talking to people
Yeah.
and looking
Yeah.
them in their ears. And yeah, yeah.
Yeah, because their dentist took it seriously, they
Ah,
start to take it seriously. They chew. They're at their dentist's office, and their dentist is bugging them and sticking their fingers in their mouth and feeling for lumps. And they say, "Oh, my dentist is taking this seriously." And the dentist might say, "Because you chew." And they come to me, and finally, maybe they're willing to switch to something else. And lately, it's been a lot of the purified nicotine pouches,
Mm,
which that's been a sea change in the last year or two. They've gone from Copenhagen to Zen,
yeah.
which is probably, quite a bit safer.
Hmm.
And because a lot of these guys can't quit, they've been chewing for 40 years
Hmm.
and it ain't going to happen. But maybe they can switch to something else. And they're willing to do it for two reasons. One, because their dentist is taking it seriously, but also because their buddies are switching. So that's been a
Gotcha.
huge change lately. Zin, zin, zin.
Zen.
One third the price if you cross the border, because in Minnesota we tax it as a nicotine product, and in Wisconsin and the Dakotas they tax it like chewing gum
Oh,
or
I was
something.
thinking the Canadian border, but no.
No,
Oh,
no,
wow.
no. Yeah,
Really?
these guys are like to their wives. It's like, let's take the motorcycle. I'm going to take you on a day trip to Hudson. Let's do something romantic. They're really there to get the one third price in. They're buying it in cases. Yeah.
Oh, yeah, it's hard to bring back on a motorcycle, I would think. But yeah,
Why don't she carries it in the back?
yeah, there you
She's got
go.
one arm around him and one arm around the cases in.
Well, okay, so now I'm going to ask you about another difference between dentistry and medicine. I mentioned in my book coming out that I haven't announced what the book is yet, but there's a chapter in what dentistry gets right and wrong and what medicine gets right and wrong. And I think that dentistry and medicine are screwed up in different ways. And one of the things that I think dentistry does right, and it's not perfect, is it has at least a little bit of focus on prevention
Hmm.
versus medicine, which is more reactive. A lot of maybe not in your practice as much, but but as a system and how it operates, it's more fixes problems versus prevention. And and I kind of think that maybe that lends to what you're saying too, where a patient goes to a dentist for more preventive services, so they seem like they're like kind of looking for warning signs more. And maybe is that and this is a hypothesis that I just came up as you were talking, that maybe that's the origin of why when the dentist says, "Oh, maybe you should look at this differently," they come back to you, and
I don't know. I I
you
don't
don't
I
buy
don't
it. It's one of my
nah.
bad
Yeah,
ideas.
it's one of your bad ideas. I think patients don't really think of it that way. They don't think of the dentist as my prevention focused person and my doctor is my reaction focused person. Partly because medicine does more prevention, I think, perhaps maybe more than you're aware of.
Hmm.
All the baby check stuff. You bring your baby in at 1 week and 1 month and 2 months and 4 months and 6 months and 9 months and 1 year and eight,
Yeah.
all that stuff. It's all pure prevention. Any yearly physical, it's pure prevention. Pap smears,
Hmm.
mammograms, all the stuff is
Yeah, yeah.
prevention, prevention, all these shots you get. So, eh,
But those screening tools oftentimes are looking for. They're not giving you guidance on how to prevent problems. They're screening for problems to solve. Not all of them, but most of them, right?
yeah, I would say I think that's true. We're screening for, is your cholesterol high? We're not talking to people whose cholesterol is low and talking about keeping it low.
Hmm.
Partly though, because I'm sure teeth get worse as you age, just by aging alone. But I
Hmm.
think if you take good care of your teeth, you can die as a 90-year-old with excellent teeth. You can't die as a 90-year-old with excellent medical health. As we age, our teeth are one of the things that hold up better than any part of ourselves. You know,
Hmm.
I- when you
Yeah, it's
when
true.
you get old, people get old. There's this myth out there that you can sort of have this aging free aging. It just
Hmm.
doesn't happen. Our cholesterol gets worse. Our blood pressure gets worse. You start dribbling in your pants.
Yeah,
You sag all over. Your cancer rate goes up.
yeah,
Like keeping healthy teeth, that you can do. Keeping somebody who's 75 healthy, even if they're doing everything right, people just get frail as they age.
yeah. And
You can't
there's
prevent that.
you can do you buy, because now there's a big And we this is one of the reasons why I wanted to have you on the podcast, because I love your perspective on longevity, which is like we all get old,
We
right?
do get old.
But
It ain't pretty.
so do you buy that you can delay it or live healthier longer?
You can certainly make it worse,
Yeah.
being a smoker.
Ah.
Yeah, try to have good genetics.
Mhm.
That's the biggest part. Of course, we have, yeah,
Yes.
we have no control over this.
Yeah.
A lot of aging is genetic,
Mm.
lots and lots and lots of it. And then on top of that, try not to be an alcoholic, try not to be a smoker. If you can manage not being 50 to 100 pounds overweight, please do, but not everybody can.
Mhm.
That's a lot of that is outside of our control to a good extent. There's just I think you have more control over your teeth than you do over other aspects of your health. I mean,
So
there's some people born with, I don't know what their enamel is weak or whatnot, or they didn't get fluoride, or their mom kissed them with their mouth full of the bad caries
yep,
bacteria.
that's true. Yeah, there's
All
a lot
these
of that.
things.
Yep.
There's these
Yeah.
things, but other than that, you can do a pretty good job of keeping good teeth until you're 100.
Yeah, well, it's great perspective, as I knew you would, and so it sounds like your longevity tip for people is to buy your Zin in Wisconsin.
Very
Yes,
truthfully,
yeah.
if you can take one of these, you're subjecting yourself to carcinogens multiple times a
Yes,
day, and instead you're just subjecting yourself to pure nicotine. If you can make
much
that
better.
switch, please make that switch. Make it today.
Well, I knew it would be enlightening and entertaining, and thank you, Allison, so much for being on the podcast. Very
I've
much.
got more to say.
Go ahead.
No, some other time.
Another time. We'll have to do another
Okay.
episode. Appreciate it.
Yeah.
Thank you very much.
You're welcome. Thanks for having me.